It's a pleasure to welcome Dr. Brian Beal.
Okay, thank you, Franco. Can you hear me okay? Everything
Yes,
okay?
I can.
Okay, good. So hopefully I'll be able to give you some more tips after Thomas's lecture. I've been asked to concentrate on what to do after surgery. So of course, we're talking about pain, and that involves a bit of neuropharmacology and inhibiting nerve transmission. And there's many different areas that we can inhibit this nerve transmission with a number of different agents, including alpha agonists, opioids, MMDA agonists, local anesthetics, and Nsaids. But what we're going to focus on in this talk is kind of this area at the nociceptor level. So we're going to focus on the area of the surgery itself. When we treat pain, we always try to go with a multimodal approach. We know that if we inhibit the pain pathways at different locations, we're going to get a synergistic effect and a better outcome. So this oftentimes involves use of local anesthetics, opioids, NSAIDs, and additional agents such as some of these supplements. So in the immediate postoperative period, this is when animals typically experience the most severe pain. And the first 24 hours, we're generally going to use injectable agents. Opioids are very, very important to us, and methadone, morphine, hydromorphone, fentanyl are probably the most common. Typically, we will actually give these for the first afternoon and evening after surgery. And in the morning, we'll go ahead and switch over to oral medications. Now, another thing that helps besides just giving medications is the first day after surgery, or the first day of surgery and the day after, is actually using cold therapy. And putting a little bit of pressure on it helps as well. So we call this cold compression therapy. And it's certainly been documented that by providing cold compression therapy for 24 hours after surgery, that we can get decreased swelling, decreased pain, and decreased lameness. So again, I typically recommend cold compression for approximately 48 hours after surgery. So we do some in the hospital, and then I have the owners applying more cold therapy at home in the home setting. And in the home setting, typically this is going to involve some sort of ice pack, as shown in these images right here. When you're using these type of administration, you want to put a light towel between the skin and the ice so that it doesn't get too cold. And you should test this on your own skin to make sure that you can tolerate the amount of cold. Another thing that I use quite often is just a bag of green peas that have been placed in the freezer. And I take that out, crunch them up, and apply it around the surgical area to apply the cold. And usually I'll do 4 applications of cold throughout the day. So approximately every 6 hours, and we'll usually apply the cold therapy for 10 to 15 minutes each session. Now, something that we use very commonly and we're very happy with in the United States is a bupivacaine liposome product called Noceta. A lot of places don't have this yet, but I'm sure you'll have it soon. And this is a microsome encapsulated local anesthetic. So these liposomes degrade over 3 days and release bupivacaine into the soft tissues surrounding the wound. So we inject this in all the soft tissues around the surgical site, and we get 3 days of duration of action of this local anesthetic. So when you dose this, you actually dilute it out to build up the volume so that you can infiltrate more of the soft tissues around the area. So again, another thing that we'll do is we've kind of experimented with the dose, and we found that it's also effective at half the dose. So to kind of stretch out or get double use out of this one vial, we can go with a half a dose and apply it to the dogs and get very, very good success for 3 days. You know, the day after surgery, the animals typically go home. we tend to transition to oral anesthetics at that time. We believe in the multimodal type of application. So in this immediate post-operative period, we're going to go with Nsaids in almost all dogs. We're also going to add on many times some gabapentin, as well as another product, which we'll talk about a little later, called Antonol. Antonol is a fatty acid type product. So we're going to use the Nsaids both to act at the local area as well as up the neurological pathway, is similar to the gabapentin. The Antonol we're using mainly for the local area as a multimodal type of a product. Tramadol is another option. However, this has kind of fallen out of favor lately and not used quite as much as the above three. Now, I guess the big question is, you've done a TPLO surgery, you've done a great job planning it and executing your surgery, and the dogs do fantastic after surgery. But the big question is years down the line, many dogs start to then develop some lameness, some loss of mobility. And the question is, well, why? Well, it's really not any great surprise. When we actually look at the literature, and again, there's not a lot of long-term outcome literature after knee surgery, but what is available, the common thread between all these articles is that these dogs always develop progressive OA as time goes on. Now, it progresses very insidiously, so they do great for a long period of time, but eventually they start to slow down and have motility issues. So again, we see this in multiple different studies. So why do they develop this problem with OA down the line when you've stabilized the stifle and they've done so well in the short term? Well, the most likely culprit is post-operative chronic synovitis. And we've proven this. We've used second look arthroscopy to look into joints down the line, and we see that it's very rare that synovium ever goes back to normal. In almost all cases, there's some degree of post-operative synovitis that lasts for the lifetime of the patient. And this is likely the cause of this very silent progression of OA. So our goal is to minimize synovitis long-term to reduce the progression of this OA. And this not only is seen in stifles after TPLO or knee surgery, we've seen the same thing on second look arthroscopy in hips and elbows. So this is something that you see in all cases of joint trauma. And we've evaluated this in over 400 cases. So how do we know that synovitis leads to OA? Well, here's just one example. Here's a dog here that has an early partial ACL tear. The other limb of this particular animal actually had a complete tear, and we repaired the opposite knee, but we scoped this knee at the time of that surgery, and you can see in this view here substantial hyperplasia of the synovial membrane. So we also saw very mild tearing of the fibers in this case here. Now this knee 3 months later looks like this. And now you can see this synovium has gotten more severe, and you can see that we now have more swelling within the joint. So this partial ACL tear is starting to progress. And this is just a blown up version of it. So here's at the time of the original surgery where we have the mild synovitis, and here's at the 3 month period later where the synovitis has gotten more severe. Now this synovitis, as it progresses, leads to these osteoarthritic changes. And you can see clearly a difference between the bony changes between these two radiographs just within 3 months. Now this is still a partial ACL tear. This is not a complete tear. There's actually minimal cranial drawer here. So what's causing this is not the motion in the knee. It's actually the upregulation of all the enzymes in the knee, these mediators that are progressing this arthritis. And again, the mediators are coming predominantly from the synovium. So what happens when these mediators come out is it takes normal cartilage, as shown here histologically and grossly, and it starts to degrade the collagen, the glycosaminoglycans, the matrix of the cartilage, leading to erosion of the cartilage as shown on this side. So this is what we want to try to prevent. We want to try to prevent the cause of this cartilage damage, and this is being caused by the synovitis releasing mediators that lead to the deterioration of this cartilage. So we did a large study where we did second look arthroscopy 1 to 4 years after cranial cruciate ligament surgery. And you can see these are 50 consecutive cases. And you can see that in every single case that we did, you can see that there is not any normal synovium. So there's not one normal looking appearing stifle here. So in essence, 100% of these cases have some degree of chronic synovitis long term. So in my eyes, we know that synovitis can cause osteoarthritis. So it would be very opportunistic to be able to minimize the amount of this synovitis to decrease the severity and chance of OA in the future. So we need to have a long-term strategy because we know that our joint is inflamed for life. There's biologic unrest. So we need to minimize that inflammation, and we can do that a number of different ways. Certainly Nsaids are the gold standard. We can give Nsaids to help keep this synovitis at its lowest level so that we are less likely to get OA or minimize the amount of OA in the future. Now, of course, Nsaids are a great product. Many dogs tolerate it very well on an everyday basis, but some dogs have difficulty with it, and we get a little bit more concerned with giving it on a daily basis, especially as a dog gets a little bit older. Another product would be omega-3 fatty acids, which also suppress inflammation. There's been a lot of work on this in different supplements and diets. The two omega-3 fatty acids that have got the most attention are EPA and DHA. Another product that sometimes is used for arthritic patients is glucosamine and chondroitin sulfate. And we'll talk just a little bit about all of these products. So one study looking at the glucosamine chondroitin type products this was a prospective double-blind study in 71 dogs. These dogs had OA of the hip, elbow, and stifle. And this was a placebo-controlled study for 4 months. And they had 4 groups. They had the placebo, carprofen, meloxicam, and the chondroitin sulfate glucosamine product. And what they found in this study was that the carprofen and meloxicam, the 2 Nsaids, improved the ground reaction forces by use of a force plate. So in other words, the animals started to improve and put more weight on their limbs. Whereas with the glucosamine chondroitin sulfate product and the placebo, that was not seen. Owners also evaluated the patients, and in their opinion, the meloxicam caused improvement, but in the other groups, there wasn't a significant improvement. So this study kind of supports the use of Nsaids for treating dogs with arthritis and improving the use of their limbs. Let's talk a little bit about fatty acids and how they work to help dogs with arthritis. So fatty acids work differently than the Nsaids to suppress inflammation. Now, Nsaids, of course, inhibit cyclooxygenase, but the fatty acids don't directly inhibit cyclooxygenase, but what they do is they affect the substrate that the cyclooxygenase works on. These fatty acids incorporate into the cell membrane in the phospholipid layer, and they change the composition of that. And so they're replacing some of their arachidonic acid units with the EPA type units. And what happens is when cyclooxygenase it actually interacts with these EPAs, they produce a less inflammatory prostaglandin than they ordinarily would if they acted on arachidonic acid. So you can see that this mechanism does not involve inhibiting the cyclooxygenase. It involves changing the substrate for the cyclooxygenase to get a less inflammatory prostaglandin. So fatty acid supplements are not all the same. Again, it's kind of like Nsaids. All the Nsaids are different too. just like fatty acids. So you don't want to just think of every fatty acid as being exactly the same. They can come from a variety of different sources, but most of them come from fish or marine oils. Now, there's a lot of different fatty acid and lipid products that potentially have these anti-inflammatory properties. In fact, there's over 90. And as I said before, EPA and DHA has certainly got the most attention, but there's many others that still need to be studied. And we know that the concentration of these can vary from product to product, as well as the handling of these products and the potential for loss of concentration and effectiveness. So I want to talk a little bit about one product, a fatty acid product, that's had quite a bit of research done in the past few years. And this is a product called PCSO 524. The brand name is Antonol, and it's produced by Vets Pets. Now, this is a patented fatty acid complex derived from the New Zealand greenlip mussel. It actually contains over 90 different products in it, including fatty acids, triglycerides, sterols, and other lipids. Now, another important fact with this particular product is it's a very stable product. And we know that a lot of the lipid products can be quite unstable and very heat sensitive. So this is stabilized using a CO2 patented extraction process to produce this stable oil extract. There's been safety data in dogs and cats, and no side effects have been found. And this product also has been shown to be able to be used with Nsaids without increasing the chance of side effects with that particular NSAID. So let's just look at one study. This study was a prospective, single-blind, 4-week study. And this looked at 40 dogs with hip or stifle OA. There were 4 groups. There was the PCSO 524, which is the Antonol. There was glucosamine and avocado soybean unsaponifiables, a glucosamine chondroitin type product. There was carprofen, and there was a combination using carprofen together with the Antonol. Now, the outcome measurements were force plate and orthopedic assessment scores. And in this study, what they saw was improvement in the force plate in all the different groups. And the improvement occurred fairly quickly within 2 weeks. So you can see that the top 3 were the Antonol, carprofen, and the combination of Antonol and carprofen. So you can see that the carprofen was slightly higher than the Antonol at 4 weeks, and the combination of these two actually had the best score. So it appears that there is a synergistic effect by using the NSAID along with the Antonol. And you can see that all 3 of these options had results than the glucosamine chondroitin sulfate type product. So again, this is very good information. We showed better use of the limb with these products or a combination of these products. This was a follow-up study that was done and was led by Duncan Lascelles. And this is a study that looked at PCSO 524, which is Antonol, and compared it with firocoxib, a different NSAID. And they looked at both of these compounds separately as well as together, or a combination of the two. And in this study, it was a 4-week study. And so the time points were 0 weeks, 2 weeks, and 4 weeks. And the outcome measures were the force plate, the canine brief pain inventory, and there's 2 different types of scores. There's a pain severity score and a pain interference score. And they also wanted to see the effect of these products on the kidneys, so they followed the serum chemistry profile. This was a double-blind, randomized clinical trial, and these dogs had mild or moderate stifle or hip OA. So looking at the force plate data, the peak vertical force, which measures how much downward pressure the patient is putting on the limb, they followed it at 3 time points, week 0, week 2, and week 4. And what they found was that all 3 groups, the firocoxib group, the Antonol group, and the combination of the two all improved at week 2 and week 4 compared to week 0. So all the different combinations seem to help. This is the data here, and you can see, just like the last study, you can see the NSAID was a little bit better than the Antonol as far as ultimate improvement, and the combination of the two gave us this synergistic effect. So the use of the NSAID and the Antonol together gives the most optimal result. As far as the CBI scores, the CBPI scores are an owner evaluation survey. And one of the surveys developed something known as the pain severity score. And we saw that this pain score decreased, so improved, at week 4 in the Antonol group. Another score that it generates is something called the pain interference score. And again, at week 4, we saw a decrease in this score, or an improvement in the patient, in both the firocoxib and the Antonol groups. So this study fits very, very nicely. The outcome of this outcome data fits very nicely with the force plate data as well. Now, interestingly, during this study, the dogs that received Previcox only, or firocoxib only, or firocoxib with the Antonol, we saw an elevation of the creatinine and BUN. This was not seen in the Antonol only group. So it appears that when you give an NSAID for 4 weeks, you're likely going to see a little bit of elevation in the creatinine and BUN. I just want to point out that these values were still in the normal range. So we did see an elevation or increase in these values with the NSAID, but it did not go outside the normal range. So in summary, there's significant force plate improvement in all the groups by 2 weeks. And the largest change was seen in the combination group, supporting a synergistic effect between NSAID and Antonol. This improvement was sustained over the length of this study. The CBPI owner pain scores improve with Antonol and Previcox by 4 weeks. There were no side effects reported with the Antonol, which is the omega-3 fatty acid type product. There was, however, a significant elevation of BUN and creatinine with the firocoxib in combination group. But these values remained in normal reference range, and these animals did not show any clinical signs of toxicity. So in conclusion, this data suggests that PCSO 524 or Antonol, Previcox, and the combination of both are beneficial in treating dogs with OA and have a lower risk of side effects than PCSO 524. But patients may have a lower risk of side effects with PCSO 524 because of the changes in the creatinine BUN. PCSO 524 appears to act synergistically with NSAIDs, whether it be firocoxib or Rimadyl, and this can be used as part of a multimodal approach to the management of OA in dogs. This study also would support the use of PCSO 524 Antonol for daily maintenance of dogs susceptible to potential OA, such as dogs having TPLO surgery. We've already shown that these dogs have a long-standing chronic low-grade synovitis that ultimately will probably lead to OA in the future. So if we can use an agent that suppresses inflammation, such as PCSO 524, with a very, very low chance of side effects, this may make sense and give your patient the best chance of a positive outcome in the long term and not just the short term.